Well, everything got quiet real quick, so I guess I'm supposed to be up here now. I want to wish everybody a good morning and welcome. We're very proud of the WCA to continue to be the regional organization that fundamentally connects the healthcare sector and the interests of the healthcare industry within the context of the broader business community. This morning is really Amy's breakfast, so I'm going to turn things over to her really quickly. I just want to thank a few of our sponsors, Health eConnections, C-Clean, Joe, thanks for coming this morning, and East River Medical Imaging, as well as a number of our board of directors here today representing some of our other sponsors. Dr. Amler is expected from New York Medical College, John Finger from the Hospital for Special Surgery, Joe Simone, the president of Simone Development Companies, and our newest board member, Stacy Petrower, who is the president of New York Presbyterian Hudson Valley Hospital. So with that, I will turn things over to Amy, and I hope you enjoy the rest of our program. Thank you.
Thank you, Michael. Good morning, everyone. Happy first day of summer. I'm Amy Allen, Vice President at the Westchester County Association. I'm delighted to welcome you to the return of our in-person all-access healthcare programs. And our all-access healthcare programs are designed to bring together subject matter experts to talk about key healthcare issues that are important not only to the healthcare providers, but to the community at large. And like many others, we pivoted to virtual programs over the past 2 years, so it's great to be back live. As Michael mentioned, we at the WCA have a long history of focusing on and advocating for the healthcare sector in our region. As we often tout, the healthcare sector is the largest regional economic engine, contributing a cash flow of almost $18 billion and employing well over 50,000. Add to that the mission of saving and improving people's lives, and it's certainly worthy of our collective attention and support. Today's program will focus on healthcare innovation, such as the use of artificial intelligence, or AI, robotics, and cutting-edge surgical techniques. We will hear about innovation occurring across many healthcare disciplines, including orthopedics, cancer treatment, cardiac care, and inpatient hospital care. There are many definitions of innovation, according to Google, but the most succinct one that I found that best describes what we'll hear today is, quote, put simply, innovation is the future delivered, end quote. So here in Westchester, we are fortunate to have access to world-class healthcare systems that will deliver that future. Our distinguished panel today is made up of representatives from many of those institutions, and it is now my pleasure to introduce each of them. Each speaker will spend a few minutes talking about their specific area of focus, and then we will have time for Q&A at the end. I would first like to introduce Sandra Bassi, Director of Care Delivery Innovations at the Hospital for Special Surgery. Ms. Bassi leads innovation initiatives that leverage innovative technologies to improve healthcare access and delivery. These technologies range from digital health to various applications of machine learning and AI in medical diagnosis and process improvement, data analytics and prediction tools, as well as motion assessment technologies and next-generation wearables. And those were the things that I could pronounce. Next is Dr. Kevin Soares, a surgical oncologist with Memorial Sloan Kettering Cancer Center. Dr. Soares and his colleagues are working to develop ways to reduce stress and improve recovery of patients after surgery. He uses minimally invasive techniques, including both robotic and laparoscopic surgery, to treat many pancreas, liver, and gallbladder tumors. He also utilizes heat and electricity to kill tumors through an approach called image-guided ablation. Next is Dr. Tamim Nazif, the Director of Clinical Services for the Columbia Structural Heart and Valve Center at New York Presbyterian. Dr. Nazif specializes in interventional cardiology and the treatment of heart valve disease. Lastly, Dr. Jamie Hirsch, the Senior Director of the Data Science and Predictive Analytics team for Northwell. Dr. Hirsch is also a physician in the Division of Kidney Diseases and Hypertension, and he leads research and implementation of clinical informatics, data science, machine learning, and artificial intelligence for clinical quality and operational improvements. There are many more details about all of their impressive bios on our website, westchester.org. So now we're going to hear from each of our speakers, and I would like to ask Sandra Bassi from HSS to come to the podium. Thank you.
Thank you, Amy. It's really a pleasure to be here and to be here in person after so many months of confinement and meetings in Zoom. So we're really glad to be here, and particularly to talk about the topics that are really close to my heart, the novel, innovative technology that have a potential to transform care. And today we will mostly focus on robotics and machine learning and AI. But before I talk more into details about how at HSS Innovation Institute we develop those technologies and how they're being deployed at HSS, I would just like to say a couple of broader words about those technologies in the larger and broader context of healthcare. The words like machine learning and AI, we hear it very often today, but 10 years ago, it was very hard to find use cases that we would be able to invest in those technologies and deploy them in the clinical setting. And it's no longer the case, which is great. And most of us are already benefiting from these technologies as consumers, because these technologies are being used to make investment decisions about our portfolios. When you go into a store, the articles that are being selected on the shelves may have been selected through those technologies, and the movie content that you may be screening on and that is offered to you through your streaming platforms is selected through those technologies. So if you work in a finance industry or retail, you've probably already seen the fast evolving aspects of those technologies. But in the healthcare world, the adoption of AI and machine learning has developed at a slower pace, and there are reasons for that. Even though the computer vision technologies empowered with AI has proved that it can save lives, and that those technologies can detect diseases, cancers, fractures, and some other conditions very early on, and that can have really impact on patients' life. But for some reason, the adoption, and there are reasons for them, has been a little bit slower. However, I think there is a consensus today that there is no point of return, and investments in AI next year are, according to a market research firm IDC, going to reach almost $100 billion next year. And the latest McKinsey report states that AI contribution to the global economy by 2030 is going to be $13 trillion, which, if true, is going to be 60% of GDP. So really impressive. I think the sooner we understand how these technologies can have an impact in our areas of expertise, the better we will be able to understand the challenges come with that and really take advantage of them. Now, I will speak from orthopedic perspective because I come from an orthopedic institution. And I think that HSS, Hospital for Special Surgery, is particularly well positioned to take advantages of these technologies, and we'll explain why. So for 12 consecutive years, HSS has been ranked #1 orthopedic institution by US News and World Market, and we have the lowest complication and lowest infection rates and lowest revision rates in the country. Also, since our creation almost 160 years ago, you can imagine the accumulation of expertise and knowledge that we have built by being only highly specialized in orthopedics, and the wealth of data that's been created and accumulated. So why is that important? Well, the AI and machine learning training really really thrives when it's trained on best practices and on high quality data. And that's something I strongly believe that HSS can provide. We also have about 30,000 orthopedic surgeries annually. Those are knee and hip surgeries, and that's the highest surgical volume in the country. So you can imagine those repetitive processes based on which we can continue to improve and train those algorithms. So that's why I think that it is not a coincidence that we are today at the really forefront of that technological innovation. So for me today, my goal today is to leave you with 3 takeaways. And I will go through these snapshots of, will provide you some use cases of those technologies that we have developed at HSS. And my goal is to leave you with these takeaways. The number one is that the primary goal of these technologies is to really improve care, quality of care, and outcomes. Number 2 is to improve the efficiency. And number 3 is you will see that these innovations happen at the various stages of a continuum of care. But regardless of when they happen, they're becoming more and more interconnected. And it is that ecosystem of technological innovation that really now has a power to transform healthcare. And as I go through those and change the way the patients experience the care and the way that the providers treat the patients. So I will go quickly through those use cases so you can have a little bit of a understanding of what that entails, and I think you will then understand better why that interconnectivity and that ecosystem is really, really important, and not just one innovation in isolation. So the first image here is an X-ray. We have developed AI-enabled computer vision technology that can, when applied to radiology images, can detect fractures with a higher accuracy than an average radiologist. And that technology was developed by a company called Imogen Technologies that was co-founded by one of our employees and benefited from HSS expertise in medical diagnosis and our large de-identify data repository to train that technology. And so nowadays that technology is FDA approved, and it is we started with the wrist fractures first, and now it's approved for all body parts. And it can assist both radiologists and primary care physicians in guiding them to better diagnose the fractures. The next example is, the image is a little bit slower, but it is a custom-made implant. And maybe through the second page you will see a little better. So the custom-made implants, why are they important? For the surgeries, for joint replacement surgeries that are very complex or that are revisions, it is very important to be precise in both how the implants are placed and in the right size, and that it fits well with the with the bone. And so in partnership with an Italian company, last year we have opened the first provider-based 3D printing manufacturing center at HSS locations. So what that means, we can print our own patients' implants on our location. We obviously don't do it for all the patients. We do it for very complex cases and for revisions, but it's just an insight of what the future could be for all our patients. And you can imagine the difference when you have an implant that it's like size fits all, that has higher potential to have complications later, as something that is really trying to perfectly match patients' anatomy, and the surgery, not only the quality of the care is better, but also the surgical procedure is easier and faster because the implant fits much more nicely into. So that is another initiative. The third one, and so that leads to when those customized implants are also being used in combination with robotic-assisted surgery, which can be robotic-assisted or computer navigation, the entire process can really have an impact on the outcome and on the quality of the procedure. So by preparing for this conference, I actually requested data from our data science team to understand like what are our, how many of these surgeries we do. And I was really surprised. I worked on these projects, but I don't know always like exactly who are our surgeons using and how many of these surgeries we do. And I was really surprised to learn that in 2019, robotic-assisted surgery, which include also computer navigation, represented 30% of all our procedures. Last year, they were 20%, and this year, year to date, it's 23%. So it is exponentially increasing. And when I talk to our surgeons, so this is relatively new technology that we are using. It's mostly applied to hip and knees and spine. We haven't done yet enough studies to prove clinical, validity, to prove that the outcomes are better. But the anecdotal findings and reportings from our surgeons and surgeons clearly indicates that there is an increased accuracy in the way how the implants are being placed. There's less cutting of the bone. The recovery is often faster with less pain. Patients have a higher mobility, and one of the drawback, I must say, is the surgeons say, like, yeah, the surgery still now last a little bit longer because you need to prepare all of this. The computer needs to digest all that information from CT scans or MRI scans to do a really precise planning. But nevertheless, it's really something that we don't see there's a returning back. It's something that I think our surgeons will continue to embrace, and that those technologies that we are using, we have already seen versions and variations of that, and they will only continue to to improve and have larger applications. So the next slide, I would like to speak actually about that little smart implant there. So when you think, and so that's why I would like you to start thinking about that ecosystem. You go from a much more data that you can now withdraw from better imaging. You create customized implants. You use computer robotic surgery to navigate and do more precision-based surgery. And then there's another level of innovation at the implant level. So for the first time, the first smart implant was performed at HSS last year. There were 2 surgeons who did it. That was the first FDA-approved also implant. We had since then a couple of other cases. We are cautious about that, but the important thing about it is that the technology that is it has an embedded chip in it and a battery that lasts 10 years. So it can collect data from the patients and about their mobility, about their range of motion, about their gait, about the steps, about the symmetry and other things that we in the past never had. So patients would have a surgery, they would come for a post-surgical visit, and they would be evaluated through the regular processes. Now that data that is collected through the sensors goes to the cloud and is in real time reported to the surgeons and clinical team who can act upon them and understand better what the recovery process for the patient is. Another big value that we see in using those technologies is that over time we do hope to collect more data that we haven't collected up and now, and more meaningful data that can help us understand and generate new clinical insights about the correlations between things that happen before surgery and the things that happen post-surgery, so we can provide even a better care to our patients. The last slide is not directly related to the surgeries, but is related to the to the assessment that can happen, motion movement assessment that can happen before and after surgery. And why is that important? This is motion capture markerless, which means it doesn't use sensors technology that can assess a patient movement in a question of minutes. So the patient would come to the clinic, there are sets of cameras, they do a certain sets of movements, and the technology generates the report about the insufficiencies, some red flags, and provides the input and the protocol, the treatment that the patient needs to follow. This report obviously is not given directly to patients, it's given to the surgeons and clinical teams who review it and then interpret it together with the patients. So it's actually to assist clinicians, not be directly to the patients. And why is that important? Because we have worked with this company to integrate our lower extremity protocols into that technology. And now that technology is being used at almost all our outpatient clinical rehab locations. Not only it's extremely efficient because it gives us clinical access, but it also standardized the care and provides with very high accuracy, measurable, objective insights and allows us to create a better standard of care across our locations. And also for the patients, provides way more information so they can be more knowledgeable and more engaged into their into their treatments and to understand if there are any red flags that they need to act upon them timely so that either recovery or that there's injury prevention can be done in a timely manner. So these are why I know I'm running out of time, but I just want to say that HSS, we strive to deliver the best quality musculoskeletal care in the world. And so by doing that, we are led to constantly innovate. And I hope that by providing you the snapshots of some of our innovative initiatives here gives you a preview of how HSS is double downing on those technologies and leveraging their potential not only to make clinical processes more efficient and safer, but also to provide better quality care and drive value for our patients. Thank you for listening.
Thank you, Sandra. So certainly fascinating to hear some of the things happening at HSS, and I look forward to some follow-up after the remaining speakers. So next up is Dr. Kevin Suarez from Memorial Sloan Kettering Cancer Center.
Thank you. Good morning, and I really appreciate the generous invite to be here with you all this morning. I'm going to switch gears a little bit and move over toward cancer care, which is my specialty. I'm focused on liver and pancreas cancer, as Amy mentioned, but we'll talk about what's going on across the cancer spectrum, not just at MSK, but in all of cancer care across the world. Let's see. Here we go. Can you go back to, here we go. Okay, so if the first robot was essentially presented in 2000. It's come a long way since then, but that's when it was first approved by the FDA. But if you do a simple PubMed search and just look at robotic cancer surgery, for example, you immediately come up with 16,000 different results, different papers that have been published on this. And if you look on the bottom left here of the screen, you can see that most of these publications are happening in the last few years, 5 to 10 years, which shows you how the field is moving along and advancing when it comes to oncologic, minimally invasive surgery. And what's really helped push this along is the fact that we've been able to centralize a lot of cancer surgery and complex oncologic procedures into high-volume centers that have had a vast experience in open surgery so that they can then move over toward a minimally invasive approach, which that open experience is actually critical, and we'll discuss that. So looking at the volume of minimally invasive and total surgeries we do here at MSK, as you can see the robot, which is in the blue line, the robot procedures have gone up essentially every year since its introduction in the early 2000s, but more specifically in the last 5 or 6 years, seen a significant increase where a larger percentage of our cases are being done robotically versus the old-fashioned way and the open incisions. And if you look at it across the different types of specialties within cancer, this one being gynecologic oncology, which Dr. Sonoda, one of our surgeons here at Westchester, does a vast majority of his cases, and his partners as well, robotically, to the point where now up over 50% of cases for things like ovarian cancer, uterine cancer, hysterectomies are all done robotically. Similarly, for colorectal surgery, this group, and led by Dr. Iris Way, who's here at Westchester as well, has also seen a significant increase in the percentage of cases they're doing robotically. Essentially, the open cases at this point for colorectal surgery are very advanced cases. Otherwise, they're all being done minimally invasively, and we'll get into the potential benefits of that approach. And even complex surgeries, thoracic surgeries, esophagectomies, lung resections, similarly have also had an increase in the number of minimally invasive approaches that have been undertaken for these surgeries. Now, not to the extent of colorectal and GYN oncology, but this also has a lot to do with what are very large operations and complex operations at baseline. And getting to my particular service, hepatopancreatobiliary, which are liver and pancreas resections, we're also seeing, especially in the last few years now, a more significant increase in the number of cases we're attempting to do robotically. And the percentage of cases had been as low as 27, 30%, but what's really allowed us to make this up near 43, 45% is the advance in the technology. The technology that was there when this was first introduced in 2000 wasn't ready for these complex approaches, but as the technology improves, it's allowed us as surgeons to be able to implement this in our day-to-day practice to ensure that not only can we get better outcomes, but appropriate oncologic outcomes, and that's where rigorous study of these technologies is necessary. So what are the benefits of minimally invasive surgery? Well, first and foremost, it's wound complications, right? We're dealing with a number of small incisions rather than one larger incision. That immediately decreases your risk of having wound infections, which in cancer surgery is a major problem because it keeps you from getting onto very important other aspects of your care, most specifically systemic chemotherapy. But also hernias. Hernias are a problem. Hernias are seen in anywhere from 10 to 20% of abdominal operations. If you have minimally invasive surgery, that risk of hernia goes down significantly. Other potential benefits, and some of these have been panned out in randomized controlled trials, others are more theoretical at this point but being studied, include things like less postoperative pain, a decreased length of stay, which is essentially about a day less or so in the hospital, improved cosmetic results certainly, potentially quicker recovery, and this last point is a big one as it pertains to cancer. The ability to get to chemotherapy earlier is key. You know, one of the things that when I talk to a patient for the first time, they're coming to see me because their cancer may be potentially removable, but there's also usually another aspect to really giving them the best chance. It's chemotherapy. And unless we can get them both of those things in a timely fashion, we're not helping those patients. And this is where minimally invasive approaches can help us potentially get to chemotherapy earlier. And if you are minimizing complications, have a higher likelihood of getting to the systemic chemotherapy, which is critically important. So I'll just give you a few examples of certain approaches we're using now in a minimally invasive fashion in the HVB sector that many years ago was only done open and where the advantages may come. This is a commonly performed operation at our institution, which is a hepatic arterial infusion pump. We place it in patients who have metastatic colorectal cancer to the liver or intrahepatic cholangiocarcinoma to the liver, which is a cancer that starts in the liver of the bile ducts. The point of these pumps is that they can give continuous medication to the liver and give the liver a much stronger dose of chemotherapy than they otherwise would get with systemic chemotherapy alone. And as you can see from the diagram here, essentially this requires taking a small catheter into a small artery that feeds the liver and can give that chemotherapy to the liver continuously. Now, up until recently, this required a large incision in the middle of their belly. It required a long length of stay, about 5 days to recover from, and comes with all those other possibilities of wound infections that I mentioned earlier, as well as hernias. And so the approach for this minimally invasive was an important one to undertake at our institution. We initially started laparoscopically back in the early 2000s, and there are limitations with what we can do laparoscopically, a lot of which is due to the instrumentation. But as the robot started to be implemented, it became clear that this is an operation that was ideal for a robotic approach, given that these procedures require extreme accuracy, very fine dissection, as well as the ability to suture. And so now we can take this catheter and place that into the artery and do it through a number of small incisions and place the pump at that time, and the patients are leaving the hospital on average 1 to 2 days after their operation. Another aspect where HPV surgery has really taken off as far as MIS approaches is pancreas surgery. Now, pancreas cancer is obviously a devastating diagnosis, and it's suspected and will be the second leading cause of cancer-related death by 2030. So the best approach for this disease when we can do surgery, which is in about 20% of patients who present initially, is to do both surgery and chemotherapy. So any approach that can get surgery done efficiently without major complications and lead them to chemotherapy earlier is an important advance to the field. And so this laparoscopic or robotic approaches and the platforms that have come with it have allowed us to use these smaller incisions, allow them for their faster recovery. And additionally, there's a lot of benefits when it comes to the visualization that you have with the robot, in the sense of motion stabilization, the optical zoom, high definition cameras, and has now become the standard for distal pancreatectomies and is being used more and more for pancreatic duodenectomies, or the Whipple procedure, which is a bigger pancreas operation. It's advanced such that there are now evidence-based guidelines that have recommended minimally invasive distal pancreatectomy is essentially a feasible, safe, and oncologically appropriate, which is, I think, a very important caveat as you understand these technologies and how to implement them, done in experienced hands. And some comparative prospective studies have been done and others are ongoing, and that's an important aspect of all of this technology, is making sure that we are rigorously studying what we're doing and that the outcomes are appropriate. Now, as it comes to pancreatic duodenectomy, this is more of a novel aspect to pancreatic surgery, but moving along in high-volume centers such as ours, and where these programs are now being implemented in a place which has enough surgery volume to do these, as well as open experience to do these. And we'll get into some of the other basics as to what's necessary. So to do these things, it requires a team. These are the rest of the partners, my partners that I work with, Dr. Alice Way and I, and Dr. Kingham, D'Angelica, Balachandra, and Drebin, and Jarnigan is a group of 7 surgeons who have all been committed to try and implement these MIS approaches in HPV surgery. And having more than one surgeon work with you allows you to get better insight on patient selection, understand anatomic and oncologic issues that are necessary, and then the learning curve is real. And so as you go through this with experienced surgeons, you can go through this safely, rigorously, and study your outcomes and make sure that patients aren't being harmed. It also takes an OR team. You know, the OR team that we do our robotic Whipples with are a team that's done hundreds of open Whipples already. And that includes the nurses, includes the anesthesiologists. And that knowledge of what's necessary in an operation and along the course of the operation is critical, in addition to the anesthesia and perioperative team. So who's a candidate for HPV surgery? Well, selection is important. Not everyone is a robotic surgery candidate. And that's the job of the surgeon and the physicians to understand which patients could really benefit from that approach. It takes an assessment of their anatomy, what the exposure or lack thereof will be, what the oncologic concerns are, in pancreas surgery especially. As you can see there, vascular involvement is not all that unusual, and those may not be the right patients for robotic approaches. So making sure that you maintain safety constraints and considerations as well as oncologic benefit is critical. So in summary, robotic approaches have certainly increased in cancer surgery over the last 2 decades. It appears to be safe and feasible, and you can do complex operations as the technology advances. And what we need to do moving forward is to continue to understand the oncologic benefit of this, as well as start to understand how to train the next generation of surgeons as they come through their training. Thank you.
Thank you, Dr. Soares. So certainly a lot of hopeful information for all of us sitting here in this room. Next, I'd like to invite Dr. Tamim Nazif from New York Presbyterian.
Thank you so much for the opportunity. It's really great to be here, and particularly in person after so long. It's a real pleasure. So I'll be speaking about another type of lesser invasive surgery, what we call hybrid surgery. This is a type of procedure that combines both a conventional surgical aspect, perhaps a small incision, with a catheter-based procedure. A catheter is a thin tube that can be inserted into the body, in our case into the vascular system, to treat heart disease. Now, as most are aware, the heart is a pump, the job of which is to take blood that's oxygenated in the lungs and pump it to the rest of the body. The heart relies on a series of 4 valves in order to do this efficiently and effectively. So every single time your heart beats, your entire life long, these valves are opening and closing. And with age and a variety of medical conditions, these valves are prone to disease. I'll be speaking specifically about one of the main valves on the left side of the heart, the aortic valve, which is the final valve by which blood leaves the heart to the rest of the body. Now, these are primarily diseases of the aging population, and they're quite common in our population, especially as the population ages. In fact, significant diseases of the left heart valves will occur in more than 10% of the population by age 75. So really common medical conditions. The specific disease I'll focus on as an example, although we've been innovating around all of them, is the aortic valve. The aortic valve, its native state, is thin, highly mobile, opens and closes readily. However, in various disease states, it can build up calcium and scar tissue that prevents it from opening. And here's some examples from pathology of diseased aortic valves. And you can imagine with those heavy deposits on the valve leaflets, how those valves will no longer be able to open. When this occurs, the blood is no longer able to flow effectively through the heart. The heart must therefore thicken to try to pump harder and eventually will fail. Patients will develop symptoms like chest pain, shortness of breath, and perhaps dizziness or passing out. These diseases occur over many decades. They can actually be fairly indolent for years. However, once a patient develops symptoms, which typically happens in a patient's 7th, 8th, 9th, or decade of life, the prognosis becomes quite grave, with an average life expectancy of only about 2 to 5 years, depending on the specific symptoms. And we've known now for many decades, beginning in the 1950s or 60s, that heart valve replacement both makes patients feel better and live longer. However, this is quite a significant surgery. This requires an open heart procedure. A patient must be placed on a heart-lung bypass machine. The heart valve is then removed from the body, and a new valve, which can either be mechanical, made out of metal and plastic, or biologic, made out of pig or cow tissues, is inserted in its place. Very effective, but a major surgery that requires, about a 5 to 7 day hospitalization and a 4 to 6 week recovery period. Historically, we've seen that more than 40% of patients with this disease are not treated. This is due in parts and gaps in diagnosis, but also in part gaps in referral. This is a difficult procedure, especially as patients age into their 80s or 90s. This is an awfully big surgery to send someone for. And so there's been substantial interest in looking for easier ways to do this. And so I'm going to be talking now about transcatheter aortic valve replacement, or TAVR. This is a procedure by which a heart valve made out of a stent, essentially a metal frame, with biologic tissue, usually cow or pig leaflets, can be placed in a compressed format onto a catheter, induced through the bloodstream, advanced up to the heart, and used to replace the heart valve. This was first conceived of in the 1990s and then performed for the first time almost exactly 20 years ago from now. This was reported by, among others, Dr. Martin Leon, who's the director of our group at New York Presbyterian Columbia. That's Dr. Cribier sharing a glass of champagne with a very ill patient the night actually after his procedure, and extended his life with that. And this really was the start of what we've called the transcatheter revolution, whereby now the majority of aortic valve replacements in the United States are performed with these catheter technologies. From those early days with Dr. Cribier, there's really been tremendous iteration, and we've been proud to lead a lot of the research in this area. We now have sophisticated valve systems that are onto their 3rd, even 4th generation, catheters that we can steer and use to navigate through the blood vessels in the heart. We perform this through a very small incision, less than an inch long, in either the groin, the side of the neck, or the side of the armpit. And here's a quick animation that will show sort of how this works. We see a patient here into the heart, the blood vessel coming out of the heart being the aorta, and there's that diseased aortic valve you see with the calcium and thickening, unable to really open. That valve is not allowing enough blood flow to support the patient's vital functions. We therefore approach it from this transcatheter aspect, small incision in the femoral artery, the artery down near the groin. We advance a wire up to the heart. We then use that wire to guide our catheters. We can use catheters, for example, that have balloons. I said the valves build up calcium. Calcium is what your bones are made out of. It can be very hard, very immobile. And we can actually use balloons, for example, to crack open the calcium in the heart, to move the old valve out of the way. We then use the same access point to advance a brand new valve into the body. We'll be seeing that in a moment. It's again crimped or compressed down onto the catheter so that it can fit through a sheath, an access site less than the size of your pinky into the body. The valve itself, once it's expanded, will be the size of a silver dollar inside of your heart. And we see how the heart's going to be now rapidly paced to create it to sort of stand still, not move at all, so we can be very precise with where we want it. And the new valve is implanted, immediately taking over the function of the old valve in the heart. And so that's transcatheter aortic valve replacement. You might ask, how the heck do we know what's going on? It's inside of your body, right? And the answer is through the use of sophisticated imaging techniques. To the top left, what we call fluoroscopy, detailed real-time X-ray imaging. The heart's being rapidly paced, and this is what we see as the doctor implanting it. To the top right, ultrasound. So we use these imaging techniques in three-dimensional ways to see inside of the heart and the body and navigate our catheters to where we want and perform the procedure. And so this has really changed, I think, in a major way the patient experience. To the left, a patient that had traditional open heart surgery, that's 7 days after the procedure at the time of discharge. The patient, and that'll be a 4 to 6 week recovery. The patient to the right, that's an hour after the catheter procedure. The patient will be out of bed eating dinner and home within 24 to 48 hours. Now, it's intuitive, perhaps, that this should be beneficial, but we don't rest on intuition in medicine. We rely on clinical trials, and we're proud to have led the PARTNER series of trial, PARTNER 1, 2, and 3, testing these new technologies. First, in inoperable patients, we started in PARTNER 1 with patients that absolutely were too sick or too elderly to have surgery at all. We then went to high-risk patients, then intermediate-risk patients, and finally, low-risk patients in the most recent PARTNER 3 trial, the results of which were reported in the last couple of years here. In this trial, PARTNER 3, we saw patients with a surgical risk level of only about 1 to 2% at 30 days, so what we consider low risk, and at a younger age than what we've treated in the past, now an average age of 73 years. These are the majority of patients in the population with this disease. And really stunning results. To the left, compared with open surgery, a significantly lower rate of mortality at 30 days, or major stroke of only 1%. Results that really would be almost unimaginable even 10 or 15 years ago. And to the right, in terms of the primary endpoint of this study, death, stroke, or rehospitalization, 50% reduction compared to open surgery. And the clinical practice in the United States and around the world really has followed these clinical trials. This is from a national registry here in the United States showing a really dramatic growth in the use of this technology, such that as of 2019, more catheter aortic valve procedures were performed than open surgical ones. 750,000 at 750 centers, many of whom we trained actually through our training courses here at New York Presbyterian. And so this is an innovation that we're incredibly proud of. It's taken over as the mainstay of treatment for this disease condition, which is common in our population. And continued research in this area will give our patients new minimally invasive therapeutic options. I focus as a sort of use case on the aortic valve, but similar innovation around mitral valve disease, which is also a common disease in the population. We have a procedure called MitraClip, where again with catheters we can repair leaking in the mitral valve. We have pulmonic valve replacement, something we perform in younger patients with congenital heart disease, and wide open research around the fourth heart valve, the tricuspid valve. I appreciate your attention, and thank you again for the invitation.
Thank you, Dr. Nazif. Again, another encouraging, fascinating, especially to somebody in the aging population. Great to hear all this, all this innovation. So last up is Dr. Jamie Hirsch from Northwell.
Thank you, and good morning. I'm not going to talk about procedures, which means I don't really have any nice images, which means I don't have any slides, so bear with me on this one. Because as exciting as the work that I'm doing might be, sitting in front of a computer or watching me write some computer code is not that interesting to put up on your slides. As my colleague Ms. Bassi mentioned earlier, AI is ubiquitous. Everyone here has AI in their pockets, probably on their wrists. I have a 1980s Casio, so no AI there. But it's everywhere. A couple of years ago, McDonald's invested $400 million in their AI team to sell more French fries. Stitch Fix, which is an online clothing store, has a chief algorithms officer. And so, of course, healthcare is getting into it too, right? So every health system, every company, they've got the newest AI-backed product, the newest AI-backed initiative. But it's got its challenges because when Netflix recommends a movie that you don't like, you just flip to the next one. If an AI algorithm recommended something in healthcare that's wrong, well, patients can get sick, patients can die, mistakes can happen. So we have to be a little bit more precise than perhaps Netflix or Amazon. So at Northwell, we've been on a journey over the last couple of years to bring data science, machine learning technologies, and artificial intelligence to bear to improve our operations, to improve the quality of care that we deliver. But for me as a physician, the focus is not on the algorithms, right? I think there are a lot of times, there's a lot of companies saying, we have an AI tool. And you go to a doctor in the hospital, you go to the nurse, you go to the patient, they don't care about AI. They just want to get better. They want better care, right? It's about solving the problem at hand. And if AI can help, that's great. But sometimes it's just a tool. And I think that's really the mindset that we have at Northwell, where we rigorously evaluate the opportunities we have to use artificial intelligence technologies to improve care across the spectrum of care and across the continuum of care. And I'm going to talk to just a couple of examples of what we've been doing at Northwell to advance the care of our patients in the hospital and at home. Our first major success, I think, developing some AI tools, which was a collaboration between data scientists, researchers, engineering teams, implementation scientists at Northwell, was early April 2020, which I don't think anyone really wants to revisit. But within a matter of weeks, Northwell had over 5,000 patients that had gone through their hospitals with COVID. And we were struggling to figure out how to balance where the patients should go. We were taking over conference rooms and lecture halls. Patients were going back and forth from this hospital to that hospital to balance and to make sure that we weren't being overloaded anywhere. And the challenge became, what's happening to these patients? Where should the patients go? Who are the patients that can safely be discharged? And we were able, within a matter of weeks, to build a tool that can provide that information and that can help our clinicians, help our administrative staff, help our EMS services figure out which patients can go where safely, which patients need to be in an ICU, which patients can go home, which patients can be monitored in different care settings. And this was a collaboration where we really worked very closely with our hospitals to make sure that we can take the safest care of our patients. And it wasn't about just building a predictive model to say, here's a probability score. It was about a holistic solution to think about what are the needs of our doctors, what are the needs of our patients, and how do we best take care of them. So fast forward a couple of years, it's been now we're on to other ideas, other technologies, other use cases. Our big focus at Northwell, and one of the major aspects of quality of care is the patient experience. And for anyone that's been through the hospital, sometimes the experience can leave a little bit to be desired. And I've gotten calls from my own patients. I've gotten calls from my grandmother. She's the biggest complaint I hear is the problem of sleep at night. Right? Nobody likes to be in the hospital. Everyone likes a good night's sleep. And unfortunately, we wake patients up. We wake patients up at 11. How are you doing? How are you feeling? 3 o'clock in the morning, let's check your blood pressure. Of course my blood pressure is high. You're waking me up. So one thing we really wanted to focus on, and I'm proud to say that the Society of Hospital Medicine just last month made this one of their major value propositions, is giving patients back their sleep. So a couple of years ago, we embarked on a project to identify which patients can we let sleep. It sounds simple, it sounds pretty straightforward, but it's a seismic shift and a culture change in how we care for our patients. We all know that patients heal better when they get a good night's sleep. I mean, who here hasn't felt better after a good night's sleep? So at your sickest, at your most, your most vulnerable, you're in the hospital and you're not getting a good night's sleep, you're not going to feel better. And so we developed a tool that we looked at 3 million patients, 30 million sets of vital signs, and we put that through algorithms that we developed at Northwell. And we were able to now identify which patients every single night in our hospital at about 9 or 10 o'clock, we say, can you go till 7 a.m. safely? Can we let you sleep, get a full night's sleep safely without worrying, without being checked on, without being poked and prodded? And I have to say, it's 99.7% accurate. It's pretty good. But we're continuing to improve it. And importantly, we're also, and this is where I think AI sometimes fails, we're looking at every single subgroup of patients, whether it's gender or sex, age, race, ethnicity, diagnoses, different care settings, different hospitals. Because what performs well at Northshore University Hospital in Long Island may not perform well at Phillips. What performs well for men may not perform well for women. I mean, there was a big brouhaha with a big an algorithm that was looking, a few years ago, a commercial algorithm that turns out it was performing excellent on a global scale, but for certain subgroups and certain racial minorities, it was performing quite poorly. And so we take that very seriously. We work with our equity teams and we work with our diversity teams to make sure that we think about very carefully, how do we make sure we don't just deliver the best care overall, but the best care to all of our patients. So our model, we call it the LSPL, or Let Sleeping Patients Fly model, is being deployed at several hospitals right now. We're going slow but steady, very methodical, studying it, making sure that it works as promised, that we deliver effective care and safe care. And combine that with another product that we're developing around identifying which patients in our hospitals are at risk of having a negative experience. We have at Northwell, all of our doctors and nurses have phones. We use Microsoft products. We use a Microsoft Teams product, which is basically it's a HIPAA secure texting solution. We developed an AI-based chatbot where we can get clinical information sent to our doctors, to our nurses, to our care teams. And now we've layered in predictive models to identify which patients are at risk of having a negative experience, which patients aren't happy about their food, which patients are at risk of having confusion at their time of discharge around which medications they should be taking and may come back to the hospital. And so now we're able now to more precisely identify which patients need different types of care, need different types of information, need different types of hand-holding, so that we can make sure that they have a better experience, that they get higher quality levels of care, and they don't come back to our hospitals, but we can see them in the outpatient, we can see them at home. Now, the list of tools that we're developing goes on and on. It's a very exciting time for us. But it's also, with a note of caution. We have to be very thoughtful about how we deploy these tools. Because as I said, it's not about, we're not trying to sell another product like Amazon. We're not trying to get you to watch another movie like Netflix or buy another pair of pants like Stitch Fix. We're not investing $400 million to sell you more French fries. We're taking care of patients. And ultimately, that's our guiding light. Right? And how do we use these tools at the service of our patients, not at the service of the tools themselves? So thank you very much.
Thank you, Dr. Hirsch. So this has been fantastic. I have a couple of questions I'm going to pose to our panelists, and I'm sure those of you in the audience have some questions you would like to ask them, but since I'm at the podium, I get to ask first. So obviously, healthcare in Westchester has expanded exponentially over the last decade, and all of the big systems are here. Many of you are representatives of those systems. Just curious if you have a sense of what has been the development of these new technologies here in Westchester, or what might be being developed here in Westchester, and how do we fit into the kind of the cog of the whole system-wide approach? So I don't know if anybody wants to take that first, or any volunteers? Dr. Nazif?
Yeah, there has been quite a bit of development here in Westchester. We offer a lot of satellite opportunities for people that have some of these problems that may need really specialized care down in the city. We do offer opportunities to be seen and to have the entirety of the evaluation here in Westchester. A lot of what we do, I didn't get into it so much, but it's based on very sophisticated imaging. And so we have new, for example, types of CAT scans that are available here in Westchester. We have new types of echocardiography, ultrasound, also available here. So we have clinics or offices throughout the county. We aim to see patients. They can see a cardiologist, maybe a surgeon, an imaging person, all in a single experience, have their imaging done, sort of have all the preparation work. And if they do need a very sophisticated procedure, even if that does require a trip to the city, we try to minimize that just for the procedure itself. So much of the care, as well as the post-procedural recovery, can indeed be done here locally, which is exciting and a big advantage, I think, for the patients.
Great, definitely.
Yeah, I mean, similar for us, the advances that are being made technologically in medicine should no longer be confined to a certain area of the country or region, right? Access is the major advance, I think, from a technologic standpoint that needs to continue. So what happens in New York should happen in Westchester. Now, there are certain limitations, obviously, major operations, major procedures, where it's a safety issue. But beyond that, things such as high-quality imaging, high-quality physicians, managing, appropriate biopsies, all of these things can be done safely in Westchester and other places around the community. Our MSK Westchester facility is essentially the same scanners, same MRIs, same CT scans, same radiologists, same medical oncologists that work in the city. And as Dr. Nazif mentioned, I see patients here in Westchester. The only time I need to see them in the city is for their surgery. And beyond that, everything else is done here, and the quality is no different. And I think we'll see more and more of that. In fact, we've started now doing even procedures here in Westchester that would typically require a trip to the city, specifically interventional radiology procedures. If a patient's deemed safe and appropriate, they can have their biopsy done here, they can have a drain exchange done here, just as they could in the city, and they spare themselves a long trip and a long day. So I think we're going to see more and more of that in Westchester and around the rest of the community moving forward.
Sandra, did you want to?
Yeah, so I agree with that. I think that nowadays, like the standards of care are, particularly within one same institutions, should be really the same, and you should be able to receive the same quality of care regardless of where you are. Obviously, there are certain real limitations. We have locations here in White Plains, but our main, for the surgeries, the main location is in New York City. But outpatient centers and rehab centers provide the similar care. I would invite the Westchester community to come and visit us here in White Plains and do perhaps that DARI assessment that that can give you maybe additional insights that about your movement that could be also, preventive, and you can see like how much more information we can now extract from these technologies. So that technology, for instance, is available almost at all our rehab clinical centers.
Dr. Hirsch, where's all your great AI technologies and things you're working on? Where's that getting derived from?
So we're very fortunate to have quite a large health system in New York, 23 hospitals, over 800 ambulatory facilities, and the data to match. And so we gather data from all of our facilities, and really try and develop a lot of our tools and technologies, some of which are kind of niche use cases, but some of which are general across the health system. And then we, as I mentioned, we validate at different sites, different locations, different practices. Our tools are being used today already on Long Island, obviously, so we have a large presence there. Staten Island, Manhattan at Lenox Hill, and practices there up in Westchester. I'm very fortunate as well to work closely with our Chief Quality Officer for our ambulatory network, Nancy Barron, who's a Westchester-based physician. And so she's a firebrand, and she's really pushing quality and innovation, and we're working closely with her as well.
Thank you. So another question. This has to do with sort of a workforce question. Probably my colleague Jason Chapin would have asked this. But what is all this AI, robotics, the growth and all this, what does this mean for training of the next generation of healthcare worker? Are clinicians going to be obsolete? Probably that's not the case. And what kind of training does the new generation of healthcare worker need? So I don't know. Dr. Soros?
Sandra and I were just talking about this before we started. These are new technologies, so obviously we're undertaking these technologies. We're doing it as a group, as I mentioned, with my partners now. The question is, at MSK, for example, we train the next generation of surgeons every year. There's 7 new surgical oncology fellows who are going to be on their own in 2 years doing these things, and it's how do you get these individuals ready to operate independently and understand the new technology that's out there and do it safely. So it's on us, and these programs are being developed, and it has to be rigorous, has to be studied, it has to be done prospectively, and it can't be at random. So we are trying to develop an actual robotic training protocol, where we spend time with our fellows on the weekends and using models, using some of the industry representatives to help us get these fellows on simulation so that they can practice, we can give them feedback, and at the time that we're in the operating room, we can work with them and tell them how to understand how to use the technology. In fact, a lot of times when I'm doing these operations, I'm telling the fellow everything I'm thinking so that they can start understanding what's going on in my mind as they start to integrate that into their own practice moving forward. So it's a major question. It's going to be a crucial part of the next 10, 15 years as we get a new generation of surgeons who are going to be seeing more and more of this in their training.
Yeah, no, I absolutely agree. I mean, I think we're very lucky to be here in such close proximity to the city and have access to these cutting-edge technologies, but it has been a major challenge to disseminate these elsewhere, especially in the country and more rural areas in particular. There are new models around training, including things like simulators. We've partnered actually with development teams from the airline industry where the simulation technologies are really much more advanced than what we offer. And the type of procedure I was discussing, there are now simulators that you can do an entire procedure in. And we've leveraged those to run series of training courses where physicians will fly in from around the country, spend a weekend or a number of days with us, have both didactic components and hands-on components and simulators and so on. But I agree, especially as things get more specialized, more technology becoming more demanding, the training burden is becoming higher and higher, and it's a challenge we have to reach.
I'm reminded of a quote that Geoffrey Hinton said a little over 5 years ago. Geoffrey Hinton is one of the fathers of deep learning, which is a pretty advanced branch of artificial intelligence. And he said about a little over 5 years ago that it's patently obvious that we should stop training radiologists now because in about 5 years, they're going to be replaced. And I'm not sure I found a single radiologist that's yet been replaced. But I'm also reminded of an adage in medical informatics from the 1980s that said any doctor that can be replaced by a computer probably should be. And what that computers, I think in all aspects of our lives, really it can enhance our lives in many ways, and computers, artificial intelligence, algorithms, predictive models, all of these things, these are tools at our disposal to help care for our patients. It's crucial that we train physicians and nurses and clinical staff to understand how these tools can best be used and how to critically appraise them, but they're here to stay. I think that's a good thing, because I think that they will make us better, and they will allow us to continue improving and take especially a lot of the things a lot of the simple tasks and the repetitive tasks that we can then get brushed away and automated. We can then then allows us as doctors, as nurses, to spend more time with our patients, actually to bring back that personalization, to bring back that time. We're not there yet. Anyone that's been in a doctor's office probably heard their doctors complaining about their computer systems and their electronic health record systems, right? They're slow, they're clunky. We have a lot of growing pains, but we will get there, and it will make us better for it.
Sandra, do you want to add anything?
Yeah, I completely agree with everything that's being said, and we get those questions a lot, like now that you have this technology that can, assess fractures better than radiologists, or radiologist is going to be out of work, or now that you have robotic procedures, are the surgeons going to be replaced? And obviously the answer is no. All these technologies that we are developing, we've seen their support tools that help improve the decisions, and they help improve the accuracy maybe on surgery, but it's still the surgeon that's doing and it's still the clinicians that needs to be there to review and provide the input and the recommendation. So actually, on the contrary, with the development of these technologies, I've seen increase of need of competency. That's why all these additional trainings are necessary. And we have added at HSS actually a whole data science team, new digital team, et cetera, to help us with those, because we need people who can have higher competencies to understand the potential and applications of those technologies and help us use them in a really safe and a better way.
Great, thank you. And I imagine that as these technologies advance, obviously medical schools and nursing programs will have to start to include these more and more. Okay, so I just wanted to give the opportunity, if anybody in the audience has a question, we do have a microphone. If you want to raise your hand, and our staff member, anybody, is it Aurora? There's a gentleman over here. Okay, that's.
Thanks. Availability of training data, obviously bias minimization, a lot of those really important things in this field. So where do you see that headed? Are we going towards like federated learning models? Maybe this is for you, Dr. Hirsch. How are we going to start to be able to share data across systems? and improve our algorithms, particularly for smaller systems and places that may not have, huge data sets available?
Yeah,
Thanks.
it's a really good question. So the question relates to the fact that machine learning or artificial intelligence, to create a model or an algorithm requires a tremendous amount of data. And that's really a function of the fact that really when we talk about artificial intelligence, under the hood, it's just basic pattern recognition. But it's pattern recognition at scale, right? It looks at it looks at tens of thousands, sometimes millions of patient data points that if given multiple lifetimes, any of us could probably figure out, but we don't have that much time. So the computer will do that in just a few minutes. So the challenge is that Northwell has a tremendous amount of data, as I mentioned. We can do a lot on our own. My focus at Northwell is very much focused on how do we make the best model for Northwell, although I work with teams, and we have partnerships to look for the opportunities to generalize that to other health systems and to share that. So there are a lot of those opportunities. There are many companies springing up talking about trying to have better data sharing. Data sharing is a huge problem for smaller health systems, for places that don't have access to as much data. How do they get the data that they need to be able to build these algorithms and models? And there's a lot of work afoot. I think it's really in an infancy. Whether it's better data sharing. Federated learning is a way to basically have everyone keep their data, but essentially share the models. And be able to kind of help kind of tweak the models a little bit better for each site without having to share data, because there's always a concern about sharing data. So I'm going to kind of tell you it's a really complex problem. It's unsolved. It's in its infancy, but there's a lot of really smart, intelligent people really thinking hard about these challenges. But it's a really good question.
Anybody have anything to add to that? No. Okay. Any other questions from the audience? A couple. There's one right there, and then the gentleman here.
Yeah, I just had a quick question. In regards to the innovation and technology, are you guys integrating blockchain? And if so, what do you see a rollout of it and a timeline in your perspective?
We're not yet at this time. Blockchain is like really cutting edge, and healthcare is really, really slow. So I think for some reasonable and some unreasonable reasons, but we're not quite there yet.
Gotcha. Thanks.
Anybody else want to jump on the blockchain train? No. Okay. We have a question from this gentleman right here.
Yeah, one of the questions I had was, with some of these data exports that are coming out of some of the equipment, for instance, the implantable devices or the implantable chips that check for mobility and range of motion, or even the COVID AI program that was built 2 years ago, what strategies have you guys implemented to take extensive amounts of data and bring it to a busy orthopedic practice, for instance, for them to be able to act upon it?
Did you hear that? Were you able to hear the question?
Just the last part for the physical, what was the last?
Yeah, I'm just thinking like even the implantable chips, that's a ton of data that's out
Right.
there. I'm just imagining a busy orthopedic practice and getting tremendous amounts of data. Like what strategies have you utilized to synthesize that information? So for a busy orthopedic practitioner to be able to run in and out of rooms, to be able to know what they could act upon.
Yeah, that's a great, and I think the whole question around the data about how it's being collected and how it's being used to make meaningful information that's being sent to the clinical teams at the right time, that's a really important component of these technologies being successful. So for instance, for those smart implants that we are now collecting a really large sets of data, and they're being collected over a 10-year period continuously, not just during one evaluation, but during, continuously. So there are platforms that are building in the back. And those platforms, that's why I insisted on the ecosystem, because all these variable technologies collect the data. But in order for clinicians and for us to be able to really make something impactful about it, we need to put that data in perspective, be able to correlate. And that's why there are digital and computer platforms that are built in the background to collect that, process it, and digest the data that is meaningful to where it needs to go. And I would just like to also, to the question around data sharing, because I think it's all connected. I think that, yes, institutions that have larger data sets can participate more in this innovation, technology innovation, because they have more, data is extremely important. That's what those algorithms are primarily based on. But they're also very, one of the reasons why healthcare is pretty slow in adoption of this, there are very rigorous regulations around how that data can be used. There are de-identification, that most of you who work in the healthcare already know what can be shared, what can't be shared. And then the other thing is we don't necessarily, like, we just made healthcare systems made epic, like electronic healthcare record transition very recently. That's just the first step in that transformation that will really need to create environments where data will need to be processed with way more computational power, way more statisticians and software engineers to be able to categorize it, analyze it, and really produce the valuable information after it. And that infrastructure hasn't been built yet. Like, each systems are building it slowly to get to that level where it can be changed with across the system. We are not there yet. I do really hope that we do, so that that access of care can be everywhere the same. But we are not there yet. And the questions around the data management, and I think those will be actually the biggest challenges that we will have to solve as we go and advance those technologies. So thank you for those questions.
So I'm going to do one last question to the group, kind of lightning round, in one sentence. What's next in the innovation forefront for you? And I'll start down with you, Dr. Hirsch.
Sure. So we're actually very focused right now on wearables and remote monitoring technology. But to the question that you asked earlier, with that, it's going to be more and more data that we're going to be collecting. Second by second data. We're awash in data. People say that we're data poor. We have too much data. We don't have enough information. And so what we're focused on is how do we roll out these new technologies? How do we collect increasing velocity and volumes of data, but make that into information and ultimately into wisdom to care for our patients? I think it's a really exciting time because we have the technologies, we have the hardware to do all of this. But it's the question is how do we translate that into the products that we can use at the point of care to deliver that best care?
Thank you. Dr. Nazif?
I think in my area, I focus on a specific disease in which the minimally invasive catheter-based procedures have really accelerated. But there's many other diseases where progress remains to be made. So I think there's going to be a lot of focus on continued innovation in technology to bring that lesser invasive type of surgery to many more patients.
Thank you. Dr. Soares?
I think for us, as we see the robotic technology improve, likely what we're going to see more and more of is essentially the image-guided surgery in the operating room, where we can start to have a better definition of operative guidance, help intraoperative decision-making, and these are already being done in some neurosurgery rooms, and I think we'll see more and more of it as we integrate image guidance with what we're doing in the operating room with the use of the robot.
Sandra?
I really agree with that. I think that the next models will be really around precision medicine, about a customized patient approach to healthcare. And I think in the orthopedic world, I think we will be able to generate way more information about the movement, to understand better human movement. Like, for instance, you're using your wearables to, you can detect now arrhythmia, and that can potentially prevent some, strokes in the heart. But around the movement, like, how do we prevent the osteoarthritis? And there's still a lot to be done in the orthopedic world around generating those insights about movement, human movement, to help us prevent those diseases, so that you don't become a patient at HSS.
Thank you. So I know we could probably have another 2-hour discussion, but these are all very busy people who are out saving and improving our lives. So I'm going to have to just ask that we all give everybody a great round of applause. You guys, everybody was great. Thank you again to our sponsors, without whom we couldn't put these programs on. And nice to see everybody back in person.